Good day, distinguished colleagues. It is really a privilege to speak to you today about a topic that is both scientifically critical and deeply urgent, which is the drivers of infectious diseases and antimicrobial resistance in Gaza during the current war. The content of this presentation will include background and context, drivers of infectious diseases, drivers of antimicrobial resistance, which is abbreviated as AMR, and interaction model between both infectious diseases and antimicrobial resistance, and immediate and long-term interventions. Before we start, we have to understand the current epidemiological landscape in Gaza, and we must begin with context. Even before the war, Gaza was one of the most densely populated areas in the world, with over 2 million people living within just 365 square kilometers. The healthcare system was already fragile, operating under chronic shortages of medicine, equipment, and infrastructure. Since October 2023, the situation has dramatically worsened. More than 1.5 million have been displaced. In other figures, more than 2 million of the population were displaced. Health infrastructure has been partially or completely destroyed. What was once manageable infectious disease risk environment has now transformed into what I would describe as an amplified transmission ecosystem. This is not just a humanitarian crisis, it is an evolving epidemiological transformation. To interpret this complexity, we must adopt the One Health framework, which recognizes the human health is inseparable from environmental, animal health. Of course, in Gaza today, these systems are collapsing simultaneously. If you have a look at this map, which is Gaza before 2023, 2.2 million people were confined in 365 square kilometers, and now they are squeezed in less than 45% of the original space of Gaza Strip. The One Health approach that I have mentioned in the introduction, as I said, focuses on not only human health, but also environmental health and animal health. The three components of the One Health approach are severely affected during the Gaza war. War causes usually system collapse, not only the health system, but all systems in any given piece of land. These systems will collapse, leading to disease amplification and AMR acceleration. Again, environmental collapse leads to health system disruption, leads to population displacement, and pharmaceutical system breakdown. The driver of infectious diseases, let us now examine the content of this part. We have several factors: overcrowding and mass displacement, water sanitation and hygiene collapse, disruption of vaccination programs, which was really evident in the Gaza Strip. Also, we have malnutrition and immune suppression, hospital infrastructure destruction. The overcrowding and mass displacement, we have the UN shelter hosting 3 to 5 times its capacities, therefore very heavily crowded displacement centers, families living in tents and schools, sometimes under the supervision of either local or international body, but in many times arbitrary camps are set in different areas where no water, no sewage system are there. Poor ventilation, of course, the resulting disease from these conditions will include, but not limited to, acute respiratory infection, including COVID-19, measles risk, scabies outbreak, which we really experienced in Gaza, gastroenteritis, meningitis, hepatitis A, polio, and many other diseases. The collapse of water, sanitation, and hygiene, which is a very vital component of any disease prevention program, can be manifested in the fact that 70% water infrastructure are damaged. Untreated sewage is flooding the streets in all over Gaza Strip. Limited clean water access. Even we have water access, we don't have containers to store or carry out this water. The level of contamination is so high that in a small study, more than 80% of water samples did not contain chlorine. And chlorine for disinfection or disinfecting drinking water is supply is intermittent, and many times it was missing from Gaza Strip. This can cause an increased risk of diarrheal diseases. Hepatitis A, we have witnessed an outbreak of hepatitis A, I think 2024, which was really very bad. More than 100,000 cases were registered, and the estimates is 300 to 400 people were infected with this disease. Cholera, the threat potential is still there, and the Minister of Health in Gaza, along with the WHO, are trying to make an outbreak plan for Vibrio cholera. I think they have accomplished this plan. Skin infections, various forms of skin infection that has never been seen in Gaza Strip were also found. Disruption of vaccination program, they called it chain damage due to electricity and the prevention of entrance of any equipment in Gaza. Supply interruptions, reduced outreach services. This can cause the risk of re-emergence of polio, and we have recorded one case in Gaza also in 2025 with the isolation of poliovirus from sewage samples. Measles and diphtheria are also risks. Malnutrition and immune suppression is they call it the vicious cycle, because when people or a group of people are poorly nourished, this will lower their immune system. The possibility of contracting infection or transmitting infection will be most likely, and thus this cycle continues because the infection also causes further immune suppression and causes poor absorption of the nutrient if it is available. Thus, malnutrition is a very vital factor, which in fact that many academics have declared famine in Gaza Strip, and I think the World Health Organization also reported a famine in the Gaza Strip. The effect: increased susceptibility and severity of infections. Hospital infrastructure destruction, of course, a very vital component of the health system is hospitals, and when there is no ability to treat patient properly, I think the risk of higher mortality will be imminent. Also, in addition to that, the poor infection control in these hospitals will lead also to transmission of the disease, the causative agent, which might be multi-drug resistant, thus spreading infectious disease and AMR. This will cause nosocomial infection or healthcare associated infections, delayed diagnosis, inadequate isolation. Part 2 of this presentation will speak about the drivers of antimicrobial resistance or AMR, the content, antibiotic misuse and self-medication, diagnostic collapse, infection prevention and control breakdown, environmental contamination, and AMR. In any chaos situation, in any disaster, in any war situation, people have poor access to antibiotics or medicines. Thus, they will rely on what is known self-medication. Of course, self-medication is commonly known in the Palestinian community even before the war, but it has increased in severity. And one of my students has accomplished her master thesis on the extent of self-medication with antibiotic, and the result showed higher rates of reaching 70 to 80% among participants. They self-medicated themselves with antibiotics. Of course, when they improve, they will try to save this antibiotic for next disease. So they incomplete courses, empirical broad spectrum use. They prefer, since no diagnostics available, they will prefer to use the broad spectrum, which covers other possibilities. The effect selective pressure for resistant microorganisms. Diagnostic collapse, no microbiology laboratory. In many hospitals, the microbiology services was stopped during the war. Thus, the treatment is empirically. Thus, we don't have the ability to diagnose the causative agent and perform culture and sensitivity, relying on empirical therapy, which will dominate, of course, the prescription of the physicians. This will increase, of course, AMR. Also, the diagnostic collapse prevents the ability of, or reduce the ability of hospital to trace any outbreak in the hospital or in the community. Infection prevention control, IBC. You know, IBC is a core component of any health system nowadays, and the collapse of this or breakdown of IBC will lead to many consequences: more infection, more AMR, more mortality or higher mortality rates. This can take different forms: shortage of personal protective equipment, sterilization unit damage, and supply of disinfectants and antiseptics also will reduce the ability for infection control and prevention. Of course, overcrowded wards also leads to ease of transmission. And during the war, hospitals not only served patients but served also the population, where the internally displaced people resided in hospitals because they have electricity and they have water, so they preferred. Once I visited Al-Aqsa Martyr Hospital, you can't really step inside, if it is, as it is a very full place. It is no longer can be called hospital during that time. Of course, this will increase the spread of MDR and infections. Antibiotic supply chain disruption, as I said earlier, unfortunately, the closure of the borders and the prevention of entering medicine has led to interrupted imports, stuck out of narrow spectrum drugs, reliance on available broad spectrum agents, and reliance on antibiotics that is no longer effective to treat patients, like the penicillin, for instance, or ampicillin for Staphylococcus aureus. This also led to selective pressure amplification, thus increasing resistance, and in the same time preventing antimicrobial stewardship program implementation in hospitals. Environmental contamination and AMR, sewage discharge into the environment, and maybe this real picture photo below this slide. A boy is walking barefooted into sewage that is seeping in the streets of Gaza. Hospital waste, of course, more dangerous than community waste, and it has the same problem with seeping in the streets. antibiotics are in wastewater. War accelerate environmental AMR reservoir. The interaction model, as we said, war leads to wash collapse. Wash collapse leads to infection increase or rise. More antibiotic use, AMR rise, because the equation is very well known that the more we use it, the more we lose it, or the faster we lose it. Meaning, if we use much antibiotic, many bacteria will become resistant to these antibiotics. If AMR rises, then harder to treat infection, higher mortality rate. This is a vicious cycle, again, caused by war and similar conditions. Immediate and long-term interventions that could mitigate some of the problems in the infectious disease and AMR in Gaza Strip. The immediate actions, of course, they are all priorities, but the immediate is emergency wash restoration. As I said, maybe 80% of all infectious disease could be prevented by providing proper wash. Mobile diagnostic labs, antibiotic stewardship in crisis setting, IBC reinforcement in field hospitals. The midterm recommendations is AMR surveillance system, which has stopped during the war. Vaccine campaign restoration, which also in a way, with the help of the WHO and UNICEF, have implemented emergency vaccination program. But we need the national vaccination campaign restoration and reach. Secure antibiotic supply chain, the long-term resilient health infrastructures, decentralizing the health services so that in a similar situation to the war, the destruction will be less to this infrastructure and can still serve people. Environmental AMR monitoring, a continuous monitoring for AMR. My final message here is, in Gaza, war is not only destroying buildings, it is reshaping microbial ecology and accelerating antimicrobial resistance. If unaddressed these days, today's crisis become tomorrow's global AMR threat. Thank you so much for your presence and for inviting me to deliver this lecture.